Bismillahirrahmanirrahim. Welcome everyone in this new meeting of Egyptian Society of Nephrology and Renal Transplantation, which will be made by the Transplantation Chapter by Professor Ayman Rifai, who is the moderator of this session today, and our speaker, distinguished speaker in the field of transplantation is Professor Ahmed Halawa, who enjoyed us many times with his distinguished lectures. And we hope to do this night, and we are sure this night to be one of his distinguished lectures. Professor Ayman Rifai is the moderator today. He is the President-Elect of Egyptian Society of Nephrology and Transplantation, and he is the co-chair of Mansoura Nephrology and Urology Center, and he is the chair of Transplantation Chapter in Egyptian Society of Nephrology. Please, Professor Ayman, start the meeting and to moderate this meeting. Interesting case scenarios in renal transplantation by Professor Halawa. Please, Professor Ayman.
Thank you very much, Professor Yasser, for your kind introduction. First of all, I would like to thank you, Professor Yasser, for your kind, continuous and sincere efforts in continuing and maintaining the CME meetings. Your efforts actually are well appreciated. Thank you, Professor Yasser.
Thank you, Professor Ayman. Thank
you. Tonight, I'm pleased and honored to introduce Professor Ahmed Halawa, one of the pioneers in kidney transplantation. And as we all know that Professor Halawa is consultant transplant physician at Sheffield Teaching Hospitals in UK, and he is also the director of postgraduate education in transplantation at University of Liverpool, and he is also the director of the fellowship in clinical transplantation organized by the Arab Society of Nephrology and Kidney Transplantation. Actually, Professor Halawa is going to take us tonight into a journey or a tour covering different and variable issues in our transplantation practice. This will be through a cocktail of real-life case scenarios, delivering several important messages in different aspects of kidney transplantation. Actually, I find that this way is much attractive and useful than delivering a routine lecture covering only one aspect. And I think Professor Halawa sharing me this view. Let's start, please, Professor Halawa.
Good evening, everybody. Thank you very much for these kind words, and thank you for inviting me to present real life clinical scenarios. I am Ahmed Halawa. I'm a practicing transplant surgeon, and to be honest, I'm still learning transplantation because, you know, learning will never end. Every day we'll learn something new. Every day we change, you know, our practice. Everything is changeable. Nothing is written on stone, except the holy books, which is different, you know, which is unchangeable. So today we'll take you through real life clinical scenarios. Just to start with, a disclaimer, we are not challenging any colleagues. We are not testing your knowledge, but we work as a team to pass a clear message. This is what we have been through and would like to pass it to you. We have done mistakes, and there are always messages to learn. Remember, it is an interactive session, so I will ask every member of the audience and you know, the scientific committee to contribute. There is no wrong answer, but there is always a better answer. So don't be ashamed. Feel free to express your thoughts. Feel free to interact with us. It is an interactive session, as Professor Ahmed mentioned, it's better to have real life scenarios rather than, vomiting a lecture or saying a lecture or talking about pathways and pathology and all other things, which is, this is dead medicine. So let us go to real life and see what we can do and what we can learn from this. I have changed the personal data and changed, aiming to hide the personal identity of the patient. So these data are slightly modified, so keep patients' privacy. Again, feel free to interact, feel free to write to us, and we'll answer your questions, answer your queries, and provide you that. Just feel free, don't be ashamed. Oh, good. Fine. The first scenario is quite wordy, but let us take it together slowly. A 23 years old lady lost previous graft secondary to non-compliance, received a kidney from her brother, 1-1-1 mismatch, has donor-specific antibodies, DSA, again, it's B53 with MFI 2,500. Flow cytometry cross-match was negative, which came as a surprise because at this level, cross-match will be positive, but it happens to be negative. Negative is negative. Of course, knowing that she's sensitized and she got significantly high DSA, apology. Knowing she's highly sensitized and the MFI, mean fluorescence intensity, is high, we give her HEG induction. 2 days later, after the second dose, she started to develop low-grade fever. We were quite worried that she got sepsis. Of course, heavily immunosuppressed patients, one of the side effects of immunosuppression is flaring up of infection. So we stopped HEG. Kidney function kept improving. Discharge home with serum creatinine 73 micromole per liter. This is equivalent to 0.6, 0.7 milligram per deciliter. Admitted on the weekend, 3 days later, this actually was on Friday. Friday in UK is a working day. With serum creatinine 170 micromole per liter. So this is significant rise. Reduced urine output, but no signs of sepsis. Because she has taken tacrolimus in the morning before she came in, random tacrolimus level was reported to be 19 nanogram per ml. Because, we give her HEG, so we give her a reduced dose of MMF, 500 milligram BD, and prednisolone 20 milligram OD. Ultrasound scan showed well-perfused BOT, swollen kidney. The biopsy is shown below. CD4 staining was negative. And this is a biopsy. I will give you a few seconds to look at it, and then we'll ask a few questions. Remember, I'm not testing your knowledge. We are learning together. And nothing called wrong answer, but there's always a better answer. Please comment on the biopsy. Any more investigations required to confirm your diagnosis? What is your management plan. And this is a biopsy. Any comment on the biopsy? Mu'tasim said ATM.
ATM. Mu'tasim said ATM.
Yeah, Mu'tasim, look at the biopsy. What do you think?
I think there is dilated irregular tubules with irregular outline. So I said this is a picture of ATM.
Yeah, and Mujtaba Zuhair suggested tubulitis. Fine. Look, we are clinicians, we are not pathologists, but we need to understand.
Professor Halawa, we have another answer.
Evacuation.
T-cell rejection, T-cell rejection.
Tubulitis, yeah, I've read,
Yes.
you know, toxicity, tubulitis, evacuation, T-cell mediated rejection. I think the focal proliferation of glomerulus. Where is the glomerulus? Where are the glomeruli? Evacuation, Ahmed Saleh. Toxicity. Fine. Let me ask you a simple question. ACR, Akram, thank you very much for this contribution. Actually, this is quite good, you know, that you're contributing, you are not shy, you tell us what you think. How many glands in this biopsy?
I think, Professor Halawa, this is insufficient kidney biopsy.
Absolutely right. Yes. Why? This is inadequate biopsy. No glands, yeah, 0 glands. So you cannot judge on the biopsy because it is inadequate. And what are the criteria of adequate biopsy to test for rejection? How many glands we need? Yeah, 10.
At least, yeah. 10 glomeruli.
Yeah, after 10, 10.
5 to
2
10.
vessels. Yes, Ben, well done. Yes. Ahmed Saleh, 8 to 10. Yeah, it's 5 to 10. Yeah, 5 to 10. And two vessels. Actually, they reported 1 arteriole, but we couldn't find it. It could be here. We're not sure. But again, it's still inadequate. Yes. Fine. So this actually happened on Friday afternoon. So we got the biopsy back on the day and inadequate. And patient creatinine is rising. What would you do? Will you wait and biopsy again? But the biopsy wouldn't get the results before Monday, so another 2 days of wait. No, actually, there's no, in this biopsy, there's no tubulitis.
Yes.
Where are the lymphocytes? There's only 1 lymphocyte here. There is another, few lymphocytes there. There's, of course, these are lymphocytes. Yeah, but this is interstitium. So by definition, no significant tubulitis. Hamid, get tacrolimus level. Yeah, tacrolimus level we have here is not informative because it's random. Patient has taken tacrolimus in the morning before she came in. So we cannot rely on. So we need to repeat it, Prof. So a morning tacrolimus before taking the morning dose. Anyway, let's move on. This is inadequate biopsy on Friday weekend. What would you do? Shall we wait for another 2 days? Shall we take a biopsy the same day and wait for another 2 days?
No, I think we should pulse him at the same time of biopsy. We don't have to wait over the weekend.
Yes, absolutely. This is what happened. we started straight away methylpred because we are hitting the weekend. There is no pathology service over the weekend. And this is life. This is real life. Yes. So any more investigations required to confirm your diagnosis? Of course, you need, this is highly sensitized patients. In addition to the biopsy, you need to check what? C4D staining, to ask the pathologist to check C4D again, and a check for DSA. We need to rule out antibody-mediated rejection. This is highly sensitized. So the management plan, while you're waiting for all these tests to happen, you have to start empirical methylpred. Why? Because it's a weekend, no service. Next.
Professor Halawa, Professor Dawla Bilal.
Yes.
Wants to comment.
Ahmed Saleh, DSA, yes.
Professor Dawlat. Professor Dawlat, do you want to comment? You have a comment?
Okay. Oh. Do you hear me, Kira?
Yes.
I have one comment. If we go a step backwards, this lady was very highly sensitized, and you gave her ATG, and she had positive donor-specific antibodies due to the non-compliance. Was this the best way to desensitize this patient by ATG? Or I should have adopted another policy of plasmapheresis and a different policy, because I expect an antigen-mediated rejection in this lady.
All right.
This is one thing. The other comment is the biopsy. It shows a very intense interstitial reaction. The interstitium is full of lymphocytes. So could this be drug-induced or just a T-cell mediated rejection, although there's no tubulitis? But there is definitely an interstitial reaction.
Yeah, but can you, yeah, thank you very much. Number one, the aim of plasmapheresis is to render the cross-match negative. You know,
but that's the point.
Yeah,
you don't always get a positive cross-match with patients like this. She has donor-specific antibodies.
Fine.
And you get a negative cross-match, which could be very deceiving.
No, actually, it would be no point, if the cross-match is negative, no point to plasmapherese these patients. Because the idea of plasmapheresis is to render the cross-match negative. We have a negative cross-match. You know, these will rebound. By all means, it will rebound. This is highly sensitized patient. The good thing is, it was cell-mediated rejection. Is, you know, by the weekend, by the treatment of methylpred on Monday, creatinine improved. So we didn't need to rebiopsy her, because one of the criteria of diagnosing rejection is respond to treatment, and she responded to methylpred. The second question is interstitial infiltration. Yes, thank you very much for this. Any kidney transplant has interstitial infiltration. This is part of the game. But any significant tubulitis, you cannot judge. Where about the, you know, in terms of antibody-mediated rejection, can you see gloms? Can you see peritubular capillaritis? The biopsy is inadequate. So the message here is, if you have inadequate biopsy and clear indications of immunological process going on, don't wait for rebiopsy. Start empirical treatment while you are preparing for rebiopsy. We don't have emergency pathology, renal pathology service over the weekend. This is why we treated her empirically. And by Monday, creatinine was improved and went home. Of course, you know, she's highly sensitized, so she will be under surveillance of TSA. But this is another issue, you know, because there's no clear answer, you know, what cut off and other things. But this is not beyond the, you know, beyond the aim of this scenario. This scenario indicates inadequate biopsy, Don't wait for treatment. Don't wait for rebiopsy. Treat. Second scenario, a 25-year-old lady who had her third kidney transplant 3 years ago with excellent function. She was kept on tacrolimus and steroid during her first pregnancy. Ultrasound scan showed viable fetus at 24 weeks of gestation, and also moderate hydronephrosis during the follow-up. I will show you the ultrasound scan picture. 1 week later, after being seen with this picture, a serum creatinine deteriorated further to 115 micromole per liter. Percutaneous nephrostogram, on picture is not shown, demonstrated obstructed ureter properly by the fetal head. And this is the ultrasound scan, perfused kidney, but obstructed. How do you manage hair graft dysfunction? Would you advise normal delivery? If she requires cesarean section, what are your precautions during the surgery? I know most of you, if not even all of you, are not surgeons, but you should be aware of what the surgeons are doing. Fine, so let's just see some answer. To start with, how do you manage hair graft dysfunction? What would you do? Obstructed kidney in a pregnant lady by the fetal head.
Yeah.
Nephrostomy, section, urologist should be on board during cesarean section, yes. Double J stent, PCN, yes. I can see good answer, yes. Yeah. So she should have nephrostomy and stenting the ureter. Well done. Okay.
Professor Halawa, if you allow me, we should consider also that during pregnancy, this dilatation could be not only, sometimes it's not always mechanical. Some hormonal changes or estrogen effect may cause dilatation of the ureter or the pelvis. Yeah, I know in this case it is obstructing, but sometimes it's not mechanical.
Yeah, but this was definitely mechanical.
Yeah, this is what definitely mechanical and responded to the nephrostomy or the drainage.
In addition, to, we cannot.
In addition to graft dysfunction.
Yeah,
with graft dysfunction.
Yeah, in addition to, if you we don't rely on single ultrasound scan picture, but we rely on the trend, because if you scan transplant kidneys, all of them have mild pelvis calyceal dilatation because it's an nephric kidney, denervated kidney. I mean,
and also most of them are refluxing grafts.
Yeah, but but sometimes the anti-reflux mechanism works, but this is another reason of the dilatation. But serial ultrasound scan shows progression of the dilatation. This is definitely indicating obstruction. So it's not it is a trend if you're looking for obstructed kidney. Fine. So let's just see some answers here. Why she didn't take azathioprine? Okay, because this is our protocol. The match, I can't remember, but it must be 0 DR mismatch. If 0 DR mismatches, we don't give MMF or azathioprine. Normal versus cesarean section, very difficult. Obviously, urology, obstetric opinion, yeah. Fine. So all of us agreed, looks like it needs cesarean section rather than normal delivery. Surprisingly, 60% of pregnant transplant patients will go through cesarean section. However, normal delivery it could be a reasonable option, but it is we're treating ourselves. Yes, she had cesarean section. The hidden catch here, it was me who was involved in her care, and I suggested Finisteel incision. And I was scrubbed with her cesarean section, so a transplant surgeon delivering a baby, it was a joke. And actually, the fetal head pushed the ureter further anterior. So it was a mistake to suggest Finisteel incision because I found the ureter with the stent very close to the incision, very close to the angle of the incision. So I decided, I learned from this. Lucky enough, the ureter was not damaged. So I learned from this for any pregnant ladies going for cesarean section should be lower midline incision to be away from the ureter because the ureter will be displaced anteriorly. Remember, I'm not holding the knife. The obstetrician, the obstetrician, he's holding the knife. So you can't control him. It's just 1 centimeter lateral, more lateral. We could have gone through the ureter. So the plan is, yes, nephrostogram, confirm obstruction, nephrostomy, and stenting. And the stenting is important to keep it during the cesarean section to identify the ureter. So don't rush and remove the stent because the surgeon, he can feel the displaced ureter easily. And lower midline cesarean section, the old-fashioned cesarean section rather than Finisteel. I mean, this is not the aim of the question. When, of course, you know, there's a lot of things with the pregnant ladies. I mean, this is a separate lecture. You know, immunosuppression is different, and you know, we'll discuss this later, Ahmed. Next. You were asked to review a 35-year-old man who received a kidney transplant 3 years ago. His baseline creatinine is 170 micromole per liter on triple immunosuppression, cyclosporin based. He told us later that he has seen the GP for possible chest infection. Wait, my friend. Abu Ghouda, wait. Wait, don't rush. He told us later that he has seen the GP for possible chest infection. He was treated with erythromycin, TDS, for 7 days. This is a common practice for GP and dentists that they give erythromycin. They love it. I don't know why. With improvement of the chest symptoms, but he noticed reduction of urine output. His repeat serum creatinine was 530 micromole per liter. Biopsy shown. So, please have a look.
Okay. This is a typical isometric vacuolization of the renal tubules induced by the CNI nephrotoxicity.
Yeah. Yeah. This is typical histological picture of cyclosporin toxicity. Would you manage this case differently? Describe the histology. We describe the histology. What's likely diagnosis? We'll mention what's likely diagnosis. Fine. But my question is, do we need this biopsy? Did we need it? So the biopsy here was not. Sure not. No, yes, no, sure not. The nitrof level is high, is indicative of, yeah. Sabah, C2, fell out of favor, by the way.
Yeah.
Still, we're back to trough. Ahmed, yes. So basically, the biopsy here was not indicated.
Yes, if you allow me, Professor Halawa, you raised a good point now that CO2 is obsolete. We have to depend on trough level. And many studies showed that when we depend on C2, there is a high exposure to nephrotoxicity by the cyclosporin. So I think back to trough level is the ideal and should not depend on C2.
Absolutely. It fell out of favor because it is not sustainable, results all over the place. There's no standardization, many other factors. We are back to the old days trough level. So this biopsy was not indicated, and there's clear evidence of cyclosporin toxicity. Of course, we should stop the offending drug, reduce, cyclosporin, and monitor the patient. This patient had a biopsy unnecessarily.
This is the importance of taking a good history from the patient, because the clue was in the history of erythromycin.
But remember, the patient told us later. So yeah. It was not a good history taken. Yes. Fine, good. So let's move on. A 57-year-old man received a kidney transplant 5 days ago with primary function. Over the last 2 days, his serum creatinine kept rising gradually. Initially, was 101 micromole per liter, which is less than 1 milligram per deciliter. Now, 143 micromole per liter. He is on triple immunosuppression, tacrolimus base, no proteinuria, ultrasound scan, well-perfused kidney with resistive index 0.8. Transplant kidney biopsy is shown below. Don't rush and have a look. Fine, spot diagnosis.
There's a team A.
Yeah, just wait for Ayman. Yes.
Okay, sorry.
Yeah. That looks it. Yeah, team A, yeah, on the right side. Tell me about the blood picture on the left side. What do you see? Is it still team A? Not Highland. Heba. Are you talking about the biopsy? I'm talking now about the blood picture. Helmet. Yes.
Yes, it shows fragmented RBCs.
Yes, schistocyte. Yes, that's right.
Yes, fragmented RBCs and
yeah. So this is a classic case of TMA.
TMA.
Yeah. We're not discussing the management because the management is easy. It's tacrolimus, change it to cyclosporin. It still could happen because TMA being reported with nearly every immunosuppressive drugs. Fine. So what else you need to know? We didn't mention the TAC level. Is it important? Is TMA related to TAC level? Describe the histological finding. We did. What's your differential diagnosis? We did. Any relation between TMA, occurrence of TMA, and the yes, iPhone for everyone? No. Idiosyncratic? Yes. Mr. Jab, primary, yes, well done. Yes, yeah, yeah.
Great.
Ischemia could happen at low TAC level. Yeah, it's not toxicity, it is idiosyncrasy to the drug. You know, I will call it idiosyncrasy. Yeah. Very rare, but happens, yes. Okay, yeah, I think, yeah. Next. A 57-year-old man received kidney transplant 15 years ago. Over the last 3 years, serum creatinine kept rising gradually, but this is 15-year-old kidney, remember. Initially, it was 131 micromole per liter, now 193 micromole per liter. He is on triple immunosuppression, cyclosporine-based. No proteinuria, ultrasound scan showed well-perfused kidney, digestive index 0.7. Transplant kidney biopsy shown below. I need a name to this pathology. This pathology is
classic.
Yeah, this pathology is where band of fibrous tissue or fibrosed part of the kidney alternating with healthy or normal part. BK.
Striped.
Is striped fibrosis. Well done. This is Mustaba. Yes. No, you're called stripe interstitial fibrosis. If you can see at the top of the slide here and at the bottom of the slide here, and this is band of fibrous tissue. Yes. No, striped interstitial fibrosis. C9 toxicity. Yes, called striped interstitial fibrosis. What else you need to know? What you need to know? We're talking about cyclosporine toxicity.
Trough level is very important.
Yeah. So the magic word here is striped interstitial fibrosis. Fine. Another question, quick question. If there is any other condition that can cause striped interstitial fibrosis? Yeah, many other conditions, by the way, you know, is not peculiar to C9 toxicity, drug-induced chronic allograft dysfunction or chronic allograft injury, many other conditions. So let's move on. So this is a picture of striped interstitial fibrosis indicating chronic C9 toxicity. Next.
So what was the management of such case, Professor Halawa? Is was shifted to mTOR? Or?
Yeah, no, I mean, we don't use mTOR at all because it's fell out of favor again, mTOR, and mTOR is a toxic drug, is associated with side effects, and the dropout rate is very high. So we started mTOR when we contributed to the 3C study, and surprisingly, all the patients on the mTOR arm were converted back to tacrolimus because of side effects of mTOR. So basically, we reduce the C9 and introduce MMF. And there's no standardized treatment. It is just toxicity, so you have to reduce a drug and add another non-toxic drug.
That degree, Professor Halawa, you are against mTOR, that we can, even in the presence of this such a toxicity of CNIs?
There are some indication to use mTOR. You know, mTOR, you have GFR and above, and you know, proteinuria less than 1 gram. But you know, based on our experience, you know, as I mentioned, you know, all these patients, we put them on mTOR, converted back, to tacrolimus because of the side effects of mTOR. They were intolerant to mTOR. So we are not mTOR center anymore based on the side effects of mTOR.
Is this patient is not on the top of the list of indications for mTOR?
Pardon?
You are not considering this patient one of the top indications considering mTOR in presence of CNI toxicity?
No, no. We can consider, but we can consider, for mTOR if the GFR above 40 and proteinuria less than 40. Sorry, proteinuria less than 1 gram. But this is based on our protocol unit experience as we don't stop using mTOR because of side effects.
Okay.
But again, this is
a center policy, Professor Ahmed.
Absolutely.
I think this is a center policy, but I think in our practice, if we are confronted with such case, the mTOR is a good option to prevent further fibrosis.
Yes, absolutely. I agree with you.
I think,
yeah, provided that you follow the Symphony study.
Yes, of course.
Symphony study, which indicating use mTOR for patient with GFR above 40 and in proteinuria less than 1 gram. You can use mTOR. Yeah, it is an option, but this is our policy. We don't use mTOR. We just reduce CNI and introduce MMF. Fine. Okay. Scenario 6. A 29 years old lady transplanted, just let me minimize this, 7 months ago. Excellent kidney function. Serum creatinine is 78 micromole per liter. Currently on sirolimus. I think you will like it, Professor Ayman.
Not so much. Okay.
500 milligram and 5 milligram of prednisolone. Her blood pressure is well controlled on prendoprel, AC inhibitor, 8 milligram OD. No proteinuria, no history of rejection. We all know that pregnancy in transplant patients should be planned. She's coming to see you in the clinic to discuss pregnancy. Counsel this lady regarding contraception, pregnancy, and lactation. Let us focus on pregnancy. 7 months, let us break it down. 7 months after transplantation. Will you advise her to go ahead and get pregnant? 1 year, stable function. Yes, 1 year, 1 year. No, wait pregnancy. Yes, agree. 1 year minimum. Yes. Stop MMF, M2, AC inhibitor, shift to other azathioprine and wait for it. Yes. Okay. Yeah. It looks, it looks like, we got the answer. Yes. Actually, she's on many medications which are contraindicated during pregnancy. Sirolimus.
Yes.
MMF. And AC
MMF.
inhibitor.
AC inhibitor. Yes.
Yeah. We have to change all these medications to azathioprine, put on tacrolimus, and change the AC inhibitor to another drug, beta blocker or alpha blocker or whatever. But she's a good candidate if she didn't have rejection and there's no proteinuria. I didn't mention rejection here because she didn't have it. No proteinuria and no history of rejection. Oh, yes. I didn't mention, yeah. So, yes, wait for a year. We have to change all these medications to drugs not contraindicated during pregnancy. Fine. Scenario 7. A 26-year-old lady transplanted 2 years ago. Her current serum creatinine is 201 micromole per liter. She has consistent proteinuria for nearly a year, 1 gram per day, following 2 attacks of rejection, which were treated successfully. She is not hypertensive. Her current immunosuppressive medications are tacrolimus, 3 milligram, MMF, 500 milligram, and 5 milligram of prednisolone. Counsel this lady regarding pregnancy. will you advise her to get pregnant? Mortism,
Yes.
risky, so risky, no. Better to avoid pregnancy. Not a good option. No, risky, high risk. No risk. Risky, high risk. Remember, you just advise, but you cannot stop her. But you have to counsel her that the high chance of this graft to fail during pregnancy and in the postpartum period. Just to take the risk, yes. Okay. Fine. So this is actually, straightforward case. Scenario 8. 46 years old male.
Excuse me, Professor Halawa.
Sure.
Yes, the risks are high, yes. Can we specify, just for the audience, can we specify the types of morbidities that can accompany pregnancy in this patient, the last one?
Yeah, I mean, the whole idea is, Professor Ta, thank you for this question, is graft failure. This
yes.
is this graft is unstable.
Yes.
In spite of stable kidney function, but she had 2 rejections and she's proteinuric. So most likely this graft failed during pregnancy and then postpartum period. So
in what way? In what way? I understand that proteinuria definitely could progress in this patient. So what type of failure do we expect as a sort of morbidity associated with pregnancy that will lead to failure of this kidney? I understand that proteinuria may progress, yes. And the mycophenolate is not wise, of course, while she is pregnant. This is another situation for the fetus. But what type of pathology is going to happen?
Yeah, in terms of pathology, it will be chronic deterioration of kidney function. She could have acute on top and postpartum hyperacute rejection as well. So many ways of failing this kidney, but usually this kidney will fail due to chronic damage even before the delivery. And this problem as well, you cannot biopsy and preeclampsia, well done, yes. The problem, we won't biopsy these kidneys. This kidney is very unstable and she's pregnant. So you wouldn't biopsy her. So complication of pregnancy and complication to the graft. So it's not advisable at all to recommend pregnancy, but you tell her that this kidney may not last till delivery. Or if it lasts in delivery, actually this patient after delivery GFR was 15 and eventually failed.
She didn't pass on to full term and delivery.
She did. And actually after delivery, GFR was 15. And landed on dialysis a few months later. But she wanted to do it. Fine. Scenario 8. A 46 years old male kidney transplant recipient, 112 mismatch, received 2 courses of steroid pulses for ACR, currently on tacrolimus-based immunosuppression. He started complaining of right groin pain during walking, requiring a regular analgesia. His recent creatinine is 176 micromole per liter with 1.5 grams of proteinuria of recent onset. Patient, transplant, steroids, groin pain. The registrar did plain X-ray hip.
Yes.
And this is a picture. A man, a vascular necrosis. steroid-induced fracture, avascular necrosis.
Yeah,
Are you happy with the diagnosis based on this X-ray?
of course, no.
Of course, no, we need
Just let us see the audience, Professor Ayman.
Okay.
Yeah.
Okay.
Avascular necrosis. Yes, Dali Ali. This is CT. No, then just a second. That Ahmed Saleh. MRI scan, not CT scan. MRI scan is the imaging of choice. Yes, you can't rely on plain X-ray. And do we need to do something else? He's complaining of growing pain one side. Do you need to X-ray or image the other side? Then, ortho referrer, and I want you to, refer, you have to refer the patient diagnosed. What about the other side? She's asymptomatic from the other side. Do you scan it? Both.
Of course.
Yeah. Actually, yes, I agree. We can't rely on plain X-ray. Sensitivity is low. And this is a MRI. Actually, it showed avascular necrosis as well on the other side. But one side was symptomatic. So in case of suspected avascular necrosis, you have to MRI both sides. Professor Ayman has a comment here. Yeah, Professor Ayman?
Yes, I think, as you said, Professor Halawa, that MRI is the imaging of choice that shows early avascular necrosis, which will never be seen by the X-ray. It showed advanced avascular necrosis. This number one. Number two, that it is a bilateral disease, so we should have image of both hips. And the value of detecting the early avascular necrosis by MRI, that we could save the joint by a simple maneuver, which is drilling or core decompression, just drilling to decrease the tension or the pressure in the femoral head, and we could save the joint. And if we repeat the MRI after this drilling process, even bilateral, we'll find a normal hip joint. So this is very important. Any patient with hip pain, any kidney transplant with hip pain on a steroid should go directly for MRI, and any early signs should be treated by core decompression to save the joint and the need of hip replacement in the future.
Yeah, fine. In terms of, referred pain, where the pain is referred.
Yeah, this is a very good point, because sometimes, and we are confronted with patient with knee pain, and the orthopedic starts to stress on the knee joint. Even some orthopedic diagnose the case as avascular necrosis of the knee joint, and actually this is a referred pain from the hip to the knee. Yeah. So even if the patient suffer from knee pain, we should image the hip joint, and to take care of the referred pain to the knee.
Yeah, hip pathology sometimes gets referred to the knee. This is the conclusion. This is the message. So if this patient presents differently, or can walk properly and have knee pain, you screen, of course, you scan the knee, X-ray image the knee, in addition to the hip. And
it is an important.
If you think of vascular necrosis, the message here: MRI scan, the image of choice, and bilaterally, because the disease is usually bilaterally. The percentage is different. Some large series, so 50%, 70%, 80%. The whole lot of things, but you have to screen, you have to image both sides. One of the,
by the way, there is some report that mTOR increased the incidence of vascular necrosis, and in our series we observed this phenomena among 30 patients who have vascular necrosis, and this was supported by some reports in the literature. So mTOR increased the risk, not only the steroids.
This is fantastic because we're lucky enough we don't use mTOR. So
Professor Halawa, we have an interesting question on the chat about the regular screening for patients with on steroid-based protocols, regular joint screening.
We don't do that. You know, we base because you know you screen everybody.
No.
Or all of them. You know, I mean, we are, of course, we have steroid-free protocol, but don't forget even tacrolimus and other immune suppression affect the bone. Will you subject everybody to screening? We rely on the symptoms. Somebody have symptoms, we have to screen him. But
the other side has no symptoms. What about your opinion in patients having high cumulative steroid dose, for example, for treating multiple rejections?
Yeah, I mean, this one as well, because we transplant highly sensitized patients, and we have incompatible transplant, you know, and transplantation against positive cross-match protocol. So we suspect, and we see them in the clinic. Any problem? Can you walk properly? Any problem with your hip? Any problem with your knee? And then you start complaining, your MRI scan.
Okay.
There is also some genetic predisposition to such pathology, and there are some reports that there are certain loci, I think it's B35 and another locus, I don't remember it, but this is common among patients with certain, I mean, HLA typing.
Yeah,
and there's some reports supporting that. So yeah, because all of our patients are on steroids, but why some develops a vascular necrosis and other are not? Yeah. So there is a genetic background in the.
But Professor Ahmed, this is association rather than causation.
Yes. Yeah.
But anyway, we will, the message here: MRI scan bilaterally.
Yes.
Suspected. We're not discussing the management because you know the management. Let's move on. Another interesting case. A 54-year-old lady received kidney transplant from a deceased donor. She has excellent renal graft function. She's on tacrolimus, triple immunosuppression base. 1 month later, she complained of memory loss and depressive mood. She's not herself. Clinical examination showed the patient to be confused and disoriented, but responsive with normal vital signs, including temperature, pulse rate, everything. Neurological examination was normal. 1 day after admission, a focal clonic epileptic fit of the upper limb occurred. Neurological status worsened and the patient went into a coma. She was transferred to the ICU and intubated. At the standard practice, you do lumbar puncture and was reported without any organism isolated. So infection was ruled out. Tacrolimus level at 13 nanogram per ml. C-reactive protein was 5 milligram per liter. C-reactive protein here, we consider it normal. What would you do? MRI, well done, 96877. MRI. Looks like, you know, we are dealing with experts here. Drug toxicity, Sabah, yes, drug toxicity. But what would you, PTLD? I don't think this is the case. MRI, posterior progressive leukoencephalopathy, brain MRI, Tahani, yes. Okay, fine. Let's just see the MRI. Yeah, okay, yeah. If you're thinking with the brain, this is the MRI. MRI to rule out press. Muhammad Habli, yes. Fine, the MRI T2 weighted image showed multiple areas of hyper intense, which is the white one, is here, signal involving the occipital, parietal lobe bilaterally, and the pons. Iman press. Next, who else I believe was press or any other pathology? Stop prograph. Sabah. Ali Taha. Press, 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 press. Yes, this is a classic picture of press. Fine. Briefly, and wouldn't go into the depth because we're not radiologists. Why T2, not T1? What's the difference between T2 and T1 MRI? Briefly, the principle. And what's the pathology here? What do you think? Why this white area? Fine. Just to cut the story short, vasoconstriction due to CNIES. Okay, this is the pathology. Yes, but yeah, and the image demonstrate what? Why the white is white? Is it ischemia? Yes, well done. T2 water. Yes, T2 detect the edema. T2 detects the pathology. T1 usually for the anatomy. Yeah, I just take it briefly like this. And the main pathology, there is edema, vasoconstriction and edema here as well. And this is why this picture gives, on T2, these white things. So, and we know the tacrolimus level is high. So will you reduce tacrolimus or stop it or change it to another drug? There is always delay for answer to come, yes. Reduce. Stop. Reduce or calm. Cyclosporin. Change. Yes, and this is what we did. We stopped tacrolimus altogether and put him back with cyclosporin. Still, cyclosporin can cause the same problem as well. But lucky enough, he recovered, or the patient recovered. So this is typical picture of press. Let's move on. Tell me when you are getting tired. A 65 years old renal
I think we are enjoying, Professor Halawa.
Shall we carry on?
I think everybody is stimulated and enjoy.
Do you mean we'll go for the 25 cases? Oh my God. Sorry. Okay. A 65 years old renal transplant recipient with stable kidney function on dual immunosuppression. Sirolimus. This was in the 3C study. And prednisone 5 milligram. Is complaining of sore mouth and multiple ulcerations. What's your differential diagnosis? Then sirolimus induced 979, I don't know, sirolimus induced, yeah, CMV.
Candida, one set Candida, herpes center.
Yeah, serious side effects, Candida. Look, we have to rule out Candida, and we'll do swabs, of course, but this is typical picture of sirolimus-induced ulceration. This was a severe form, and patient. What's the treatment of sirolimus-induced ulcerations? Of course, this is a very bad case, but even if it was mild, what would you do? M2 reduce? Yeah, I agree. All of us agree. What the treatment? What would you give? Aphthous ulcers. It's not aphthous ulcer, it's sirolimus-induced ulcer. Stop, change to MMF. Any local treatment? We give, mouth lotion, steroid-based, so steroid, the treatment, and local anesthetics, yes, lidocaine, yes. Yeah. But the disease was so severe, we stopped sirolimus, and we took him off the trial. And this is why we are not, this is our center-based experience. We're not sirolimus fan anymore. 11.
I think this is one of the major indications to stop sirolimus. The other two indications, I think, the resistant edema of the lower limbs, that's also sirolimus associated, some sort of lymphedema that will not resolve except after stopping sirolimus. The other thing is the mTOR-induced or sirolimus-induced pneumonitis. So these are three major indications to withhold sirolimus: mouth ulceration, resistant lower limb edema, and pneumonitis.
Yeah, to be honest, sirolimus is not a strong immunosuppressive drug. So we have highly sensitized patients, many highly sensitized patients. So sirolimus is not the drug of choice in this group of patients. So we prefer CNI rather than sirolimus. Sirolimus, actually, our mainly two indications are, but this is again center-based, intolerance to CNI, and some case we'll discuss later, skin cancer.
But did you find this side effects similar with the everolimus, Professor Halawa, in your practice?
We don't use everolimus at all. We use sirolimus.
Okay.
Because we got a cheaper offer. We pay less for sirolimus.
Professor Dawlat Bilal, I think, wants to comment.
I fully agree with Professor Ayman. I had 2 cases of lymphedema, which did not resolve after discontinuation of sirolimus. And also, I lost 2 patients with pneumonitis. They get a very nasty pneumonitis. So really, sirolimus doesn't have a very good history with me, at least.
Yeah. The same with us, actually, Professor Dawlat, because when we tried sirolimus, we tried in the sirolimus arm in the 3C study, which is a major study involved, a multi-center study in UK, and surprisingly, the dropout rate was very high. I would say around 60 to 70% of the patient dropped out because of side effects. So it's a toxic drug. We feel it, we are intoxicating patients with sirolimus. And the indications for us is if he's intolerant to CNI or skin cancer, especially,
yes,
we'll discuss later.
Yes.
But I think you as a surgeon also hate sirolimus because of the wound dehiscence and lymphocytes.
Yeah, but this is a different story because we have a CNI conversion protocol. If those patients who were in sirolimus and coming for and non-renal operation, we have to stop sirolimus a month before the operation, convert them to tacrolimus, and then put them back. To be honest, you know, we'll never put them back. The intention was to put them back on sirolimus after the operation. If they tolerated tacrolimus, we'll keep them with tacrolimus. We don't like to mess around with immunosuppression that much. So the wound dehiscence, yes, is one of the issues. However, there are many trials suggested that you can use sirolimus de novo one. To be honest, you know, we have enough side effects of mTOR. We're not using it. Fine, somebody's TB. Oh, just let's see. 36-year-old man, right renal transplant from his brother, who presented with loss of weight, night sweat, night fever, associated with deep pelvic discomfort. He has an excellent kidney function. Currently, he is on tacrolimus-based dual immunosuppression. What's your differentiating diagnosis? TB. Pyelonephritis renal abscess. Exclude TB. PTLD CMV. Any other investigation required? PTLD, TB mostly. Ali Taha. Is he Professor?
I would like to have an abdominal CT scan. Could be TB, but is there any possibilities that this TB is elsewhere apart from kidney? I mean,
yeah. I mean,
so as abscess with this presentation, would you think in that direction, or is it a bit too far?
No. Nothing too far. We're very close. But this is a typical presentation of PTLD. PTLD, the problem with PTLD presents like infection-like symptoms. Night sweat, night fever, loss of weight. But I agree with you, Professor Tariq, we have to rule out infection and we have to rule out TB by all means, because both pictures are similar. This patient, because had deep pelvic pain, the registrar requested CT pelvis. And the CT pelvis demonstrated iliac lymph nodes, big ones. And you can see the ill-defined borders is quite risky picture, or is not clean one. Yes, need CT pelvis. That's it. Is it, you know, are you happy with the diagnosis of PTLD? EPV, PTLD? This is not the objective of this question. Any suspected PTLD should have CT, chest, abdomen, and pelvis. So what the registrar did is inappropriate, is incomplete. So we have to CT scan his chest and abdomen to see the extent of lymphadenopathy. Remember, PTLD in transplant patients is different from lymphoma in non-transplant population. Usually this is the presentation, usually is extranodal. But like enough, we have some lymph nodes here. So it could be organ, visceral involvement of PTLD. And most likely this is the case. So the message here, don't get distracted by one image, but you have to complete the screening. So CT, chest, abdomen, and pelvis. Yes, repeat. Yeah, okay. Rule out infection, CT, chest, abdomen, pelvis. So this
We have a question. We have a question about Epstein-Barr PCR, Professor Halawa. What's your opinion?
Say it again.
Epstein-Barr PCR. Epstein-Barr virus PCR.
We will discuss this in a different scenario, but the objective of this scenario is incomplete imaging, and the picture of PTLD is similar to infection. So you rule out infection and put PTLD in your mind when you investigate. Infection screening is negative. Infection means bacterial infection, viral infection, CMV, other things. And then you think of PTLD if you would like to aim for PTLD of chest, abdomen, and pelvis. The EPV discussed in 3 different scenarios later on.
What should be considered here, I think?
Of course. EPV is part of the differential diagnosis, but we are discussing imaging here.
Okay.
Scenario 12, a 35-year-old renal transplant recipient who dropped his hemoglobin by 4 grams immediately following his renal transplant. He passes blood-stained fluid per his drain. Ultrasound scan demonstrated diminished perfusion of the kidney, no collection. His vital signs not changed, no tachycardia, no hypotension, nothing. Outline his management plan. What would you do? Hemoglobin dropped by 4 grams immediately after the operation. He passes blood-stained fluid in the drain, renal artery dissection, hemoglobin associated, recheck, ultrasound, ABB. I think ABB, this is a previous one. Wait, repeat hemoglobin. Fine, you repeat, maybe the repeated hemoglobin came back the same. Hemodilution. See, Ahmed Salah, CT scan. Why CT scan, Ahmed? Blood transfusion first, CT scan. Mu'tasim Sayyid. CT angio, Ahmed Shahata. Actually,
Professor Dawla wants to comment.
I can see.
I'm not a surgeon. As long as he's seeping blood out of the drain and no collection is detected by the ultrasound, so something is wrong with the anastomosis. Blood is coming out. Where is it coming out from? It's either the vein or the artery bleeding, the anastomosis itself. I'm not a surgeon, but I'm just...
No. I mean, look, this patient was managed by our nephrologist. We are always panicking about drop of hemoglobin immediately post-transplant. And ultrasound scan didn't show any collection. CT scan showed this.
That's a perirenal collection?
Yeah. What collection could be, Professor Dawla? It's passing blood in the drain.
It must be either blood or urine.
It's blood. It's nothing else. It's blood.
It must be blood, yes.
Yeah, it's blood. Why is not picked up by ultrasound scan?
Yeah, the sonographist is not clever enough.
No, the ultrasound scan actually is not sensitive enough.
Yeah.
Not sensitive enough.
If it's retroperitoneal, it will not be detected by the ultrasound. It should be. Yeah, retroperitoneal collections should be detected by CT scan.
Absolutely. Yes. So this is what happened. Our nephrology colleague didn't send him for ultrasound scan because we know we lost one patient before because of bleeding, because we relied on the ultrasound scan. It was a major disaster affecting our unit. and we've been subjected to a lot of investigations. And then based on this, we changed the protocol. It could be hemodilution, but there's no harm to put him through the scanner, provided that is hemodynamically stable. So non-contrast CT scan. Is it contrast or non-contrast CT scan? You're not a surgeon, you know.
Non-contrast.
Non-contrast. Why non-contrast? Non-contrast CT scan. No, it doesn't. None. Yeah, Samuel. Yeah. I mean, just to give you a clue, if you see here with the cursor, these are the iliac vessels that are not opacified. So it's a non-contrast CT scan. And this is what we normally do. Non-contrast CT scan first, suspected bleeding, the radiologist straight away will inject contrast if he's not sure. But this is a very clear case of bleeding. So nephrologist rang up, you know, the surgeon straight away, and we took him from the radiology to theater, evacuating the hematoma. And as Professor Ahmed said, this was just the tip of the iceberg. The hematoma was spreading into the retroperitoneal space up to the liver. Surprisingly, most of the patients we opened for bleeding, this patient was on warfarin. Anyway, I didn't mention this. The bleeding is not coming from the anastomosis. The bleeding usually coming from the hilum. Because the surgeon always worry about the stitches, put stitches well, but the problem actually, the vessels torn in the hilum, especially with deceased donor transplantation, always the source of bleeding. And to add to the excitement, usually we'll never find the source of bleeding. When we open evacuation hematoma, pack him. If he's hemodynamically stable, close the abdomen, 2 big drains, hemodynamically unstable, pack him, close the skin over the pack, and still oozing. We'll put him in the ITU for another day or 2, bring him back to theater, and open, take the packs, and hopefully, but this patient was saved. So the message here, suspected bleeding, CT scan. Don't waste time by doing ultrasound scan. It's not sensitive. In addition to, it's operator dependent. Yes, we can give contrast whenever needed. Yes. It is life-saving and such. Yes. We don't care about contrast nephropathy. We're talking about life and death here, bleeding.
Professor May wants to comment.
Hello, everybody.
Hi, Professor May.
Professor Halawa, I expect with this drop of hemoglobin that he will start to be hemodynamically unstable. What do you think?
No, but this is what happened. There is a shock of 4 stages, first and second stage. This patient already on beta blocker. So most of our patients on beta blocker, so won't be tachycardic. And what happens, they will become stable, then crash. And when they crash, there's a point of no return. It's not like normal non-renal failure patient who become tachycardic and hypotensive, sweaty, can't be sweaty. No, it's not the picture in our transplant patients. We are dealing with mysterious patients, multiple medical problems, loads of medications. The picture is completely muddled. So in this case, suspicion, contrast CT scan. Even the non-contrast CT scan came back negative. I can sleep at night.
Okay.
I make sure there's no bleeding, but not ultrasound scan. I don't like you to go through the same experience, losing patient, and then you change your protocol to non-contrast CT scan. Scenario 13, a 54-year-old CKD5 patient on hemodialysis for 6 years. She has ileal conduit, for urine diversion. You are not a surgeon, but my nephrology colleagues can answer this question. I'm sure you should answer this question. She was on the waiting list for the last 5 years, her BMI 35, bit fat. Received a kidney offer from a deceased donor, 0-0 mismatch, no DCA. That's her abdomen, and this is the ileal conduit. Any special consideration regarding the technique of surgery? You're not a surgeon, but you need to know the principle. You need to know what the surgeon is doing. What's your surgical approach if you were the surgeon? Any surgical consideration if the donor is living related. What's the effect of urinary diversion on the short and long-term outcome of transplantation, especially ileal conduit? Go back again. Where to put a kidney and how? So the ileal conduit in the right iliac fossa and Halawa transplant in the left iliac fossa for keep long ureter. Agree? Yes, well done. Yes, keep long ureter. Other side, Akram. Upside down, well done. Who said upside down? Akram is surgery. Are you a surgeon? Yes. So with ileal conduit, kidney upside down, but same site of the ileal conduit. Why? If you put it on the other side, you need a ureter to cross this scary abdomen, and this is usually the case. Long ureter associated with ischemia, necrosis, strictures, all side effects. Also, how on earth are you going to cross this abdomen with the ureter? So this is where I'm going to put the kidney, and I put it upside down. With the presence of ileal conduit, I'm sure in Egypt and the Middle East, there's a lot of cancer bladder, and there's a lot of urinary diversion, and ileal conduit is one of them. You need mesh closure. No, we don't come to this. If you need to use the mesh for closure, you use it. But the principle here is the kidney upside down, same site. Better to have a long ureter. High BMI is the main risk, of course, is one of the risks, but also to lose weight. But upside down kidney, same side of the ileal conduit. Let's move to next. This is an This is an interesting case during the workup of a donor. This is the image, 1-1-1 mismatch, no DCA. All other workup was very satisfactory. Comment on the image, please. Patient is not hypertensive. This is the donor. He's not hypertensive, no proteinuria. Everything was spot on, bang on, ready to go. Farid beaded, FMD, beaded. Which side? Both sides, right side, left side. FMD, right. Yes, right, FMD, yes, yeah, I totally agree, 100%, yes. This is a classic picture of FMD in asymptomatic donor. We used to see them, I'm sure you see them as well in your center because you do, living transplant quite a lot. The question here, will you take his kidney? Can he donate? No. Yeah, to be honest, I agree, for many reasons. It might be hypertensive later on. And if you look at this image, this is a very shreddy artery. How on earth, of course, if you need to take kidney, you have to take the abnormal kidney, not the healthy one. There's no FMD here. But it could be here, but not detected. So imagine beaded artery with aneurysmal dilatation. So taking this artery and smoothing this artery, it will be a nightmare. There are many case reports about transplanting kidneys from FMD patients. But my personal belief, it is a surgical challenge, a surgical adventure. And if you look at these papers, there is no long-term follow-up. It's just case report. We have done it. Whether the kidney survived or not, what happened to the donor? No idea. Nothing is clear. And this is why you shouldn't be guided. You have to be careful. You have to be critically appraise all these articles and think whether are they valid and the methodology is appropriate or not. We turn down all these patients because we don't know the long-term outcome of them, and they will be followed by the GP. When they have deterioration of kidney function or become hypertensive, they will refer this patient to our nephrologist. Are you okay or tired or fed up?
I think everybody's enjoying it. I don't know if they are sharing me the same feelings or not. Let's have the opinions of the...
Happy to continue, Ahmed Saleh. Ahmed Saleh is always happy. Continue. Oh. A 36-year-old kidney transplant recipient developed this lesion 14 years after his cadaveric transplantation. Currently, he is on tacrolimus. Trough level is 8.3 nanogram per ml. MMF 500 milligram PD. He has excellent kidney function. Creatinine is 113. He developed this lesion. This is a spot diagnosis.
Okay.
KS, Kaposi sarcoma, Kaposi sarcoma, Kaposi sarcoma, Kaposi sarcoma, Kaposi sarcoma, Kaposi sarcoma, Kaposi sarcoma. Looks like I'm dealing with expert. Yes, it's Kaposi sarcoma. What else you need to exclude? Professor Ayman?
I think this is extensive cutaneous Kaposi sarcoma, and I'm expecting that it could be visceral Kaposi as well. We have many patients with Kaposi in the liver, in the intestine, in the lung, and we have case with Kaposi sarcoma on the vocal cord, diagnosed by laryngoscope, Kaposi in the buccal cavity. So extensive cutaneous Kaposi necessitate the further investigations for the internal organs. We have a patient with the hematemesis and melena that came in to emergency, shocked, and we found that there was a big lesion on endoscope and the stomach, and the biopsy proved that he had Kaposi sarcoma. So such Kaposi means that this patient is heavily immunosuppressed, and we should search for visceral Kaposi.
Fine. So what is the immunosuppression of choice in these patients?
mTOR, of course. Oh, okay, sorry.
I know that you know. Yeah, mTOR, and this is actually our indication for mTOR because it responds well to sirolimus.
Professor Dawlat Bilal want to comment.
Sure.
Yes, I can't unmute myself.
No, you're not muted.
Are you hear me? All right.
No,
I agree with Professor Ayman. We have to stage because sometimes we have stage 4. It depends, and the treatment will depend upon the stage because it's not only changing the immunosuppression, but sometimes you have to give other immunosuppressants for stage 4, for instance, or visceral Kaposi sarcoma. I remember I had a case with Kaposi sarcoma in the graft itself. So it's not just only switching to sirolimus. It has to be staged for the further treatment.
Yeah, fine. This is what we normally do is, yes, once you diagnose, we refer to the oncologist. And one of the treatment of choice is the tacrolimus changed to sirolimus M2. And we'll leave
what
it.
What was the fate for this patient, Professor Halawa, after conversion? Did it resolve, actually, or what was the?
Yes, yeah. The complete resolution. I don't know the fate of this patient, because we lost follow-up, but it's been demonstrated, been shown clearly that sirolimus is effective in Kaposi sarcoma, not other cancers. However, a reduced incidence of basal cell carcinoma, squamous cell carcinoma, other cutaneous malignancies, and other malignancies as well. But post-transplant malignancies, but in Kaposi is very effective. It's very effective, but provided that patient tolerates it. So the objective of this case, the following: this is extensive cutaneous. You have to rule out visceral. Think of mTOR. Refer to the oncologist. Staging is important. Role of HIV screening. Of course, there's role. Actually, the transplant patients are very, very safe. Why? In terms of HIV, because we screen them regularly for all virology, HIV, hepatitis. However, this case is not related to hepatitis, but virology screening is a must in our center. Fine, let's move on because, there's loads of cases to go. We answered this case. Fine, a 36-year-old renal transplant recipient presented with rise in serum creatinine. He received immunosuppression, tacrolimus-based Doppler scan demonstrated 3 by 2 by 7 centimeters lucent collection near the upper pool of the kidney. No evidence of renal artery stenosis or hydronephrosis. His tacrolimus level is 16 nanogram per ml. How would you manage this case? This is ultrasound scan, sorry. Reduce stack level, ultrasound. Reduce FK. Don't call it FK, Salwa, because FK is gone. FK506, this is a name, the code name given for this drug in the trial. What about this collection? Dr. Jamila Drain, Wissam Nifosil, Conservative Mu'tasim, Seroma. Yes. I think I agree. This is actually you reduce tacrolimus dose because it's tacrolimus toxic. And regarding the collection, is anterior to the kidney, is not causing any symptoms, leave it alone. Don't stick a needle, don't call for complications. Yes, conservative treatment is the right answer. So don't get excited by a collection. You need to know the size, where is it, and the symptoms. Imaging will help. Fine. Scenario 17, a 34-year-old lady received a kidney transplant 3 months ago with stable kidney function. She's complaining of frequency of micturition, 10 times a day. Routine ultrasound scan showed multiloculated collection above the bladder. How would you manage? What's your differential diagnosis? So the bladder is here, and this is a collection. What's your differential diagnosis? Infected hematoma, gynae consultation, urinoma, drainage and chemical analysis, hydronephrosis, Jamila. This is a multi-septated collection causing frequency of micturition. Of course, we have to rule out UTI, and this is easy by doing urine dipstick. This is initial screening and send urine for microscopy and culture. Hydronephrosis, septated lymphocyte. We am septated collection, lymphocyte, or CT guided drainage, Dr. Tahani. Drainage. Yes. This is a typical picture of symptomatic lymphocyte, multiseptated collection. CT-guided drainage, and as one of the colleagues mentioned, biochemical analysis, make sure it's not urine. This is a standard practice. However, the picture gives impression is not a urine leak, but we have to rule out urine leak. What happens if the collection recurs? What would you do? Hematoma, lymphocyte, urinoma needs drainage chemistry. Yes. Yeah. This is differential diagnosis, but this is definitely lymphocyte. Yeah. Fenestration in none. Marsupialization. Yes. Okay. The treatment is right. So basically, if you have image-guided drainage, whatever ultrasound or CT-guided drainage, and recurred, you have to change your practice. You have to do something else because this one is not working. Either to put the drain for longer time and let him go home with the drain, or fenestration, marsupialization, open drainage, whatever drainage is, but you have to change your practice. You have to do something different. Inject chemicals, yes, you can, but we prefer not to. Fine. So I think the message was clear. This is a differential diagnosis we mentioned, and this is a typical picture of the symptomatic lymphocyte for guided drainage, and then if it recurs, proceed. But we have, because frequency micturition, you have to rule out infection first. 18.
I think we got an important message from the last two cases, Professor Halawa, because in our routine screening of our patients, it is not uncommon to find collection around the graft. But the idea is when to interfere. I think interference should be, it depends on presence of symptoms, pain, fever, frequency of micturition like this case. I mean, we should not put a needle in each collection, otherwise, the problem starts with putting this needle. We introduce infection, we may hurt the graft, induce bleeding. This is a very important message from the last two cases. We should not interfere in every case with the collection.
Yeah, so don't get excited with the collection. Assess the patient. Also, deterioration of kidney function. Or Doppler scan showed
yes, of course,
reduced flow.
Back pressure or
So these are pressure symptoms. So a collection with pressure symptoms or infection, you have to interfere. Otherwise, follow up. If the collection very close to the hilum, I will worry. And actually, the radiologist will be hesitant to stick a needle because it could be sticking needle into the renal vein or the iliac vein or the iliac artery. So I have to be very careful unless very symptomatic. Fine. This is an interesting case. I came across this case on my own call 15 years ago, but and I will never forget it. A 71-year-old lady was admitted with abdominal pain and diarrhea. She had cadaveric renal transplant 3 years earlier, end-stage renal disease secondary to unknown etiology. She has history of recurrent UTI, urinary tract infection, treated as outpatient with multiple courses of ciprofloxacin and nitrofurantoin. Initial stool tested positive for C. diff toxins. Patient was treated with hydration, oral metronidazole, you call it Flagyl. The immunosuppressive regimen includes cyclosporin. Initial white cell count was 16,500, rose to 19,900 after 48 hours of therapy. Abdomen was mildly distended, tender, but no rebound tenderness. What would you do? Iman, yeah, vancomycin, CT, yeah, okay. CT scan of the abdomen on the left revealed diffuse colonic thickening with scanty ascites. A plain, of course you have plain first, a plain abdomen demonstrated an 8.9 centimeter transverse colon in diameter. This was the diameter. So transverse colon diameter is 8.9. And basically the CT scan showed sick colon. Toxic megacolon, toxic megacolon, toxic megacolon, toxic megacolon. Been for surgery, cut more than 6 centimeter. Toxic megacolon, toxic megacolon, toxic megacolon, megacolon. Yes, this is a diagnosis. What's your management plan? Will you carry on treating and you give her vancomycin, give her whatever? What she needs compression, colonoscopy, Akram. Decompression, sorry. Safi. Yeah, we're talking about management, what would you do? Colonoscopy, give an enema, rectal tube decompression, vancomycin oral plus IV, Safi, rectal tube, reduce immunosuppression, rectal tube, vanco oral plus IV, CMV, colonoscopy is not recommended in megacolon, HEVA, oral vancomycin plus decompression, urgent surgery, Ben. Are you surgeon, Ben? Colectomy and decrease immunosuppression, surgical, Ahmed Saleh. Actually, this is, this me go back to the, yes, this is a really urgent case. Toxic megacolon, cutoff 6, transverse colon. Yes, this is the right diagnosis. Secondary C. diff. Don't wait for any other treatment. This patient needs his colon out. Call the surgeon and ask him to take this patient to theater. And this what happened is being seen by my nephrology colleague who called me to take him to theater. In spite of being mildly tender. Why? Because immunosuppression masks the symptoms. The colon was paper thin and nearly 7 holes sealed off with omentum wrapping. And the operation is total colectomy. His colon, all colon has to come out. I wouldn't go into the details of surgery because the distal stoma you need to deal with, but no colonoscopy, no rectal tube, no any hanky-panky, don't wait. This is surgical emergency. It's not only the decompression, it's colectomy. Because what we have seen in Fiesta was worrying. So it took him same night of the diagnosis.
What was the intraoperative findings, Professor?
Yeah, I said seven holes in the colon, but see, wrapped by the omentum. So and the colon was paper thin, very thin. So okay. if we left it overnight, he could popped. Okay. And miss the patient. A 68-year-old woman, lady, was admitted with diarrhea and normal kidney function. She had a cadaveric renal transplant 3 months ago. End-stage renal disease, secondary to APKD. It's not important, this. She received a kidney from a CMV positive donor. She was CMV positive, so positive to positive. She received a ATG induction for steroid-resistant semi-dated rejection 3 weeks after transplantation. Routine infection screening and ultrasound scan of the kidney were normal. Quantitative CMV PCR reported negative. Diarrhea not responded to treatment. MMF. Yeah, okay. We stopped MMF. Didn't get better. Because, you know, any patient with diarrhea automatically, I can't remember this patient in particular was MMF, but this is our standard protocol. We stop MMF with any patient with diarrhea for a few days till patient recovers.
Even on long term, Professor Halawa?
No, it's not long term.
Long term.
No. I mean, because infective diarrhea, well, sometimes if it's intolerant to MMF, would, you know, break down the doses, reduce the dose, introduce myphotic, or not responding to these, will give it other fibrin. But this is not the message here. The message here is CMV positive to positive with CMV PCR negative and having diarrhea, not responding to medical treatment, colonoscopy biopsy to exclude invasive. Colonoscopy. Mustafa. Yeah.
Professor Said Khamis wants to comment.
Yes.
Professor, could we rule out diverticulitis? The patient has autosomal polycystic kidney disease because it can be there also. Diverticulitis.
Yeah, of course. Yeah, I mean, diverticulosis, you mean? It's collagen disease associated with polycystic kidney and other things as well, like, you know, high incidence of incisional hernia with this patient. But here, the objective of this is CMV positive to positive, negative PCR, diarrhea not responding to treatment, had colonoscopy. And the colonoscopy demonstrated here inflamed colon. Let's make it that simple. And biopsy, this is a standard practice when you do colonoscopy, showed CMV Mustafa, yes. Actually, yes, it was CMV colitis. This is giant cell inclusion. Is it common to have, this is what we call it now, what we are dealing with is tissue invasive CMV.
Yeah.
Do we have, is it common to have tissue invasive CMV with negative PCR?
I think it is common, but it's usually overlooked.
Now, repeat PCR negative. Yes. CMV below limit. I had a case, Muhammad Abdulbari, of course, yes. Safi, yes. Less common. But we're talking about this case. Yes. Actually, tissue invasive CMV, you know, the sensitivity of PCR is low or lower. You have 20% chances of tissue invasive CMV with negative PCR. So even if you have the message here, if you have still negative PCR, you know, don't be comfortable that it's not CMV. It still could be CMV. CMV pneumonitis, CMV nephritis, CMV colitis, and gastritis, and pancreatitis could be associated with negative PCR. 20% chances of the PCR to be negative in tissue invasive CMV. And we rely on the biopsy to look for inclusion bodies. If we are lucky to get them, this patient responded to treatment. A 46-year-old potential kidney donor came forward to donate to his brother. He has excellent kidney function because we don't need to discuss, you know, the workup, but 111 mismatch, no DSA, CT scan showed angiomyolipoma, left kidney 4.6 centimeter in diameter. I put the diagnosis here to make life easy, where I'm sure, you know, when you do living transplant, you see these quite a lot. This is the angiomyolipoma, post images here. And here is 4.6. Will you accept this donor? What's angiomyolipoma? What are the risks involved with angiomyolipoma? Tuberous sclerosis, well done. Yes, I can see tuberous sclerosis. Try not to, write an abbreviation, Khaled, because, not everybody, I hate, yes, I hate abbreviation, by the way. I'm not coping with abbreviation. Is this image adequate? What
No.
are other diseases? Why?
I think brain CT also should be done to rule out or in the calcifications. So CT is not enough.
Yeah, we need to rule the other side. This
Yeah.
is one side. Yes, yeah. So we need to make sure that is usually in many occasions there are multiple. Fine. So we need to know excision during transplant, tuberous sclerosis, APKD, risk of bleeding, excision during transplant, malignancy should be excluded, then donate a biopsy, exit tumor, bench surgery, Rabia, hi everyone, MRI diffusion. Yes, we've taken this kidney because this is abnormal kidney. In addition to bench work, excision of the angiomyolipoma, and transplanting this kidney. Of course, 4.6 is the cutoff, because the cutoff is 4, but I hate the cutoff for one main reason, because the radiology can give you any cutoff you want. So, the imaging is not sensitive in measuring the, diameters and depth. We have to take this kidney, we have to do bench work and excise the angiomyolipoma and transplant it into the intended recipient. Risk involved. If we left the angiomyolipoma, what's going to happen? What are the risks involved with angiomyolipoma? Bleeding, yes. What else? Can it turn malignant?
Malignancy.
Yes. What kind of malignancy?
Angiomyosarcoma.
Liposarcoma, yes. Yeah. Okay, so we didn't do any selective imaging to check the function. It's a split function because we decided this kidney has to come out and bench work. The risk of operating on this patient, to be aware that, transplanting a kidney with excised angiomyolipoma, so you will leave around 5 centimeter size hole in the kidney and you pack it and cover it, is bleeding. Have you seen the image of bleeding I presented before? Yes, and this is the case. Bleeding.
Do you see?
Professor Halawa, I think you were lucky in this case that the angiomyolipoma was peripheral and excisable during transplantation, but sometimes we find it in the parenchyma. Hilar, yes. Yeah. So the decision, but at the end of the day, we should don't forget that this is a benign lesion, and we have transplanted so far 3 cases of angiomyolipoma, and the oldest was at 1999, so it's now 20 years. And the follow-up scans for the increasing in size or transform to malignancy or bleeding, they are so far they are stable lesions and stable kidney function. So I think the worry is the big masses for fear of bleeding. Otherwise, we can accept solitary lesions, not multiple, and of small size.
Fine. So you stimulated me to just ask another question. Fine. If you have multiple angiomyolipoma as a component of tuberous sclerosis, what
the mTOR maybe
absolutely. This is another but it's not it's everolimus actually. The trial,
everolimus, yes.
The trial is everolimus.
Yeah.
So there's another indication, but this is not a transplant patient. You know, so they give them, and there is protocol. They measure the size. We'll see the response. You know, repeated MRI scan. But remember, mTOR inhibitor plays a role in angiomyolipoma, if not operable.
But as general rule, the multiplicity of any lesion or the bilaterality is a contraindication, whether this was a stone or the mass or sometimes cysts. The multiplicity and the bilaterality is contraindication. So we always think about a single lesion or a single stone, unilateral. So I think we should stress on this on living donation.
Or multiple lesions. Yeah, we remove two lesions, two small lesions by on one side. You know, so the kidney has two holes. So unilaterality is important, but the message here, angiomyolipoma, this donor, you have to take this kidney and bench work, transplanted, counsel the patient risk of bleeding. We add to this, if multiple bilateral part of tuberous sclerosis, this is our role of mTOR inhibitor, especially everolimus. Let's move to next.
Yes.
A 56 years old CKD5 patient received a kidney from his sister. EBV positive to positive. So IgG, of course. After transplantation, we do routine APV PCR. 3 months after transplantation, the lab reported 435 copies per ml. What's your management plan? Dr. MTAG, follow up, still, decrease immunosuppression, reduction in immunosuppression drug, and follow up. Only follow up for yes. Assess hepatic status, antiviral, lamivudine. This is too much, Salwa. Decrease MMF, mTOR, follow up, liver function, follow up, follow up. Yeah, do you need to image or PTLD? Follow up. Yes. Actually, this is a norm for EBV positive to positive. Usually they will have copies in their blood, PCR, after transplantation, in the range 4, 5, 6, 700 copies. This is effective immunosuppression. What we need is just follow up. No other treatment, no antiviral, no reduction of immunosuppression. This is the norm in EBV positive patients. If you screen them, no need for imaging. Management plan is follow up to check APV PCR. So this is a learning objective from this scenario. Let us move to uncertainty now, because we will be diving into a dark deep sea shortly. Scenario 22, 11 years old CKD5 received a kidney from DCD, donation after cardiac death, deceased donor transplant, cadaveric transplant. His EPV PCR is positive after 3 months of transplantation. Reported 16,350 copies. Are you worried? And why? Or you are not? Or this is normal? What about if BC, if normal, just follow up? we're talking about scenario 22 now. PTLD, very high risk. 96879. PTLD, very high risk, reduced immunosuppression. Is Professor Al-Qusi on the call? Is not. Unknown donor status. Okay. DCD donor is an adult donor. So PTLD case high risk, imaging reduced, immunosuppression.
Hello, can you hear me?
Oh yes.
Yeah, I am on the call, but just someone is muting me. That's it.
No.
I am from the beginning for this nice case.
Yeah. I you know, we need you for interaction because you know, we're presenting one of your cases, or just we modify the personal data to hide patient identity. Fine. So the message here, this is a child. Child always, or I'd say more than 90%, to be EPV negative. Received a kidney from an adult. Adult more than 90% EPV positive. So it goes without saying, adult to a child, to EPV positive to EPV negative. And if you have this worrying number, or even less than that, I would worry about PTLD, because this is actually high risk patient. As you mentioned here, this is high risk patient. What would you do? Reduce immunosuppression. You may or may not, and this is where the uncertainty is, image him, CT scan to rule out PTLD. Reduce immunosuppression drug. Yes. So the message here, children, EPV negative, and EPV negative patient tends to be positive, high risk of PTLD, especially children.
I mean, can I have a comment?
Sure.
Yeah, the question is when you will start to be worrying. We don't know. And you can see cases with the, EBV PCR of around maybe 200,000 copies.
Just
And
wait for the next case, Mohsen, because next case is similar to yours.
Right. Okay. What I'm saying is, still you don't know for sure when you are going to do it. Anyway, just let us wait for the.
Fine. So a 41 years old CKD5 received a kidney from a DCD, adult to an adult, EPV positive to positive. Is EPV PCR is positive after 3 months of transplantation, 22,350. I changed the figures, but very high. How would you manage this case? You are worried. Fine. So I presented the 3 cases of EPV, different forms, different shapes, different patients category. Mohsen, will you just please comment on the EPV?
Yeah. So the question is,
first of all, please.
Yeah. So we don't have a cutoff to say that this is the worrying someone, and we need to do something as a high risk of PTLD or not. We reduce the immunosuppression, and I mean by reducing the immunosuppression, it will be the MMF or azathioprine, if the patient on azathioprine, and we will keep the tacrolimus and the steroids. Imaging-wise, we will do the PET scan rather than the CT scan, and this is probably also applies to the case has been presented before. The PET scan would be able to pick up small lymph nodes. You might need to biopsy at some point, because the conclusive answer here will be the biopsy or the tissue diagnosis, whether you need to do anything further or not. do we need to interfere if the, say, for example, reducing the immunosuppression by stopping the MMF didn't make a huge difference to the number of copies of EBV virus? There is no specific antiviral treatment for EBV. This is the bottom line. Some people said just the IVIG. There is no specific antiviral, but all do not apply. And there is some experience with the hematologist, with the bone marrow transplant, to say that try the rituximab for those patients with the EBV positive might help. It definitely helps on the short term, but long term, it doesn't make any difference. So it might reduce the level or the burden of the EBV PCR level within the next, say, for example, 4 to 6 months, but it will rebound again. So it doesn't make any difference. So the clue here is PET scan. If there is any biopsiable lymph node, biopsy it, and this will give you the clue whether there is any PTLD or not. If there is no biopsiable lymph node, I will monitor and see how things going. If the PCR is improving, great, which would be the case, in most of the post-transplant. And this case of this 230 dropped down now to around 3,000. And probably we might need to persevere with a small number of this PCR level of BV virus, around some viremia of around 3,000, 2,000, and we will carry on with that. Because you can't, damage the kidney if you don't have a certainty or a clear diagnosis of PTLD. I hope this helps.
Yeah, thank you very much. What about the cutoff of the PCR? We should interfere based on it.
Very variable. Some people suggest between 4 up to 10,000 copies. You need to do something about the immunosuppression. And by immunosuppression, it is mainly the antimetabolite, which is the mycophenolate or azathioprine.
Yeah. And do you think it's whole blood or serum?
And it's a whole blood, the plasma. You just take the blood and edit a sample.
Yeah, I agree. Oh, look, yeah, no, there's no cutoff. There's no agreed cutoff as well to interfere. And also, for adults, we don't know how we measure it. Is it whole blood or the plasma? So there is no university between labs. We haven't any agreement of how to do it and when to do it.
And there is no agreement between the hematologist and nephrologist.
This is
really, there is no agreement. What we can do.
Thank you very much, Professor Khusi, for this.
Professor Halawa, let me thank you for the last 3 cases. You addressed an issue which is forgotten, I think, in our clinical practice, which is the EBV infection. Usually, we are concerned about CMV, PK, but the EBV, we don't search for it. We don't follow it in our clinical practice. The majority of us. So I think the message from these 3 cases that we should pay attention more and more during our transplant follow-up to the EBV infection. Actually, it's a serious and forgotten issue. Thank you very much.
Yeah, especially in children, because they are EBV negative, and if the mom and dad donating means EBV positive to negative, this is definitely a high risk, and children are high risk of developing PTLD.
Yeah, sure. Thank you.
Fine. So let us.
I think this is the last one, or
no. There's 2. Are you tired? We can make this last one if you want.
Okay.
Yeah. So
I'm enjoying, but I'm afraid.
Really? Okay. It won't be that long. Anyway.
Okay.
So a 37-year-old man admitted after 1 episode of hematuria, and he had a successful 3rd renal transplant 15 months ago. 202 mismatch, negative flow cytometry cross match. Actually, I checked the DCA because I got patient's name, and the DCA was negative. Showed B53 on one occasion, but DCA, but the level was reassuring. His creatinine has risen from 151, 1.5 milligram per deciliter to 233 micromole, equivalent to 2.2, just roughly. Ultrasound scan showed mild dilatation of pelvic cell system, which you normally see with all transplants. Not different from the previous scan. So basically, there's no evidence of obstruction here. He's currently on tacrolimus, trough level 13 nanogram per ml. MMF 1 gram, BD, prednisolone 5 milligram OD. You notice he's already heavily immunosuppressed. Why? Third transplant. Actually, to tell you the truth, this kidney failed 2 years later and another kidney. So I had the fourth transplant. Still surviving with the fourth kidney transplant was G4 53. I checked it today. Anyway, he's currently on tacrolimus, yes. His BK viremia, he developed BK viremia because we monitor BK PCR for log 10, which is basically significant. Biopsy of the cortex. One core was taken for CV40, staining is shown below. One core, and this is a biopsy. BK nephropathy, reduced immunosuppression, MMF, tag, loflunomide, thank you. Ahmed Saleh, BK nephropathy, fine. Okay, BK nephropathy. How did you diagnose BK nephropathy? Why with this biopsy? Can you tell me, can you read this biopsy? CV40 staining. Is it positive or negative? BK nephropathy. No staining seen, Ben. No staining. No staining. No staining. Salwa inclusion bodies. BK nephropathy. Rising creatinine. Negative inclusion bodies. iPhone to everybody. Decoy cells. This is not urine test, by the way, Sophie. Fine. The message here, do you think, let's go back to the scenario. This is definitely negative for SV40. Yeah. This is negative. Let me just. So do you think it is adequate biopsy for a specialist done for BK, because we know that he has got BK viremia? Yes. Why it is negative? Is it, my question is it adequate biopsy? Focal? Fine. Usually need two. Well done, Ahmed Saleh. 2 cores, one from the medulla. Yes, this is the right answer. This is an inadequate biopsy because you have, for BK, you have to take 2 biopsies deep enough to get the medulla, because the BK affects the corticomedullary junction and the medulla. In spite of clear evidence of BK disease, the biopsy was inadequate. So the message here, if you think of BK, 2 cores, not 1, because 2 cores increase sensitivity by 30%. And the biopsy should be deep enough to get the medulla.
So in this case, we could consider this biopsy as a false negative
Absolutely.
biopsy.
Yes, yes. Actually, it's inadequate as well. So it's not done properly, just single core, not deep enough to get the medulla. So these are the catches with the BK. I think I don't need to bother you with the last one. Fine. Just quick question. This patient got deteriorated kidney function. This is actually the first patient we have seen after repeat the biopsy. So what do you think about this biopsy? Quickly. Look at the tubule in the middle. We are clinicians, we are not pathologists, but we should recognize it. Tubulitis, yes, yeah. Look, all these are lymphocytes. All these are lymphocytes. So this is tubulitis. Yes. Thank you very much. I hope that, we spend some, an exciting night together. And
thank you very much, Professor Halawa. Yes, it was very, very exciting, Amir, and exciting journey along different aspects in our transplantation practice. I think a lot of messages and lessons we have learned tonight in an interesting and enjoyable way, despite we spend around 2.5 hours. But I think it was very, very enjoyable. And this confirmed what I said before, that giving lessons in transplantation through life case scenarios is much, much enjoyable and useful than giving only routine lectures. Thank you very much, Professor Halawa.
Actually, thank you very much for this, and thank you for the audience, because the interaction was great.
Yeah, thank you for the audience, and they were experts also. I mean, a lot of right answer. Yeah.
Much more than we expected, Professor Halawa. The interaction was much more than we expected.
I think, to be honest, I was quite positive about it, because this is what we like. We like to discuss clinical scenarios rather than discussing pathways and mechanisms, which is, it kills me. I'm sure it kills all.
Yes, clinical interaction.
Yes,
it's much more interaction.
All right.
Okay.
Any more comments?
Many more thanks for you on the chat now.
Thank you very much, everybody, and hopefully we'll see you again sometimes in few months. All right.
Sure.
Thank you very much.
Okay.
Thank you.
Thank you, Professor Ayman. Thank you, Professor Halawa, and thank you for all the audience for keep running this long track with us, and enjoyable track, and we all enjoy the case till its end. 25 cases, much more information, each case 2 or 3 messages, and one important message and one more side message. Please keep on these messages, and we will try to summarize these messages in the coming days through our websites. Thank you, Professor Ayman. Thank you, Professor Halawa, again. Thank you for this long journey. Hope to meet you next Wednesday in another journey, HDF by Professor Hisham Al-Sayed and Dr. Tariq Tantawi, and I think we will enjoy it also. Thank you.
Thank you, Professor. Thank you very much.
Thank you for this very, very nice meeting, and excuse me to close and this enjoyable night. Thank you very much. تصبحوا على خير جميعا. شكرا.